Hello, everyone. Welcome to 9 to 5 Wellness Podcast. Happy Wednesday. We are recording this on a Wednesday afternoon for my guest and then kind of early evening time for me. And today we are talking about tight shoulders, nagging headaches. I know, you're familiar, right? And the thing is, both of these symptoms, they ruin your focus and productivity at work. And I also know from my experience as an exercise physiologist that you feel like you're alone, you can't get things done. On top of it, you have this headache that's like chronically bothering you. You can't do much about it. So you're tired of endlessly cycling through medications, temporary fixes, and maybe you've been bouncing from specialist to specialist. Let me tell you one thing. You are not alone. And that's why I was like, I want to discuss this topic here on 9 to 5 Wellness. I've seen so many busy professionals who often complain that, oh, if we could be just headache free most days of the year, you know what? We would get so much more done. So today we're taking a deep dive into the physiological connections between the neck, the nervous system, and chronic head pain or headaches. We are going to break down the main culprits like text neck. And if you've been listening to my podcast, you know exactly what I'm talking about. If not, we are going to decipher that for you today too. Poor sleep posture and stress. And on top of it, what is the most important thing I think today is going to be, we are going to provide you with some actionable steps and science-backed solutions that you can use immediately. And I have an amazing guest today who is an expert on headaches. As a matter of fact, he's known as the headache doctor. Dr. Jono Taves is a Mayo Clinic-trained doctor of physical therapy and headache specialist who focuses on chronic and complex headache disorders. Throughout his career, he noticed a troubling pattern. Many people suffering from persistent migraines and daily headaches, and they were cycling through medications without ever addressing the underlying drivers of their pain. So I'm super excited to dive into this topic with him. Welcome to the pod, Dr. Taves.
Yeah, thanks so much for having me. I'm excited to be here.
Thanks for joining us. I think you're the perfect person to talk to about headaches, and that is something so common. You know, every now and then, my family members, people who I work with, they're often complaining of headaches. So I want to focus on you first, though. Tell us about your journey to becoming the headache doctor. How did you get into physical therapy, and how did your focus shift towards headaches and neck pain?
Yeah, so my journey starts, I went to the Mayo Clinic in Minnesota, and I learned very foundational anatomy, physiology, neuroanatomy, how our brain functions, all things that are essential to understanding what our healthy bodies should function and look like. And so what happened was, in my physical therapy education, there wasn't necessarily a robust understanding or an equipping of headache or migraine disorders. But what happened was I learned from a few providers that were experts in treating the neck and the jaw. And so I remember taking just like a weekend course on the mechanics of the neck. And then I went and shadowed this gentleman, and he was having people from all over Minnesota come to see him because of his expertise in the neck. And it was all very manual therapy focused, so hands-on. And I just really, his confidence and his ability to help people that weren't necessarily seeing relief with other approaches, that was very attractive to me. So I started doing that early on. So the first year of my practice, I was doing just about everything from, shoulders, knees, hips, but I was also doing some neck. And what would often happen is people would come in with different types of headaches. But probably 3 or 4 months in, I had my first migraine patient, and they told me that they had seen multiple neurologists. And yes, they had this migraine diagnosis, but ultimately they didn't want to take medication. It wasn't really helping, and they knew that they had a neck issue. And so they just kind of put two and two together and really encouraged me to just, hey, can you work on my neck so that we can see if it helps my migraines? And at first I was like, I don't like this, feels like a neurological thing, but sure. And so I worked on her neck and her migraines went away. And so my response to that initially was like, okay, was this misdiagnosed? What happened here? But patient after patient, it was the same story. They had the migraine diagnosis or something that was perceived to not be a neck issue. We treated their neck and then they got better. And so, long story short, I looked into what the research was providing for these neurologists to guide their practice, and it sort of was empty of anything objective. So the underlying problem was being missed, and it was really just symptom management. And because it was symptom management, and I was finding something objective with these patients, it may sound, and it shocked me at the time too, that our healthcare system, it's like, okay, you're saying we've missed this whole thing. The dynamics at play are really fascinating, but because our Western model has had such a strong grip on this migraine diagnosis, and physical therapists should really, with our background, be understanding it, but we don't. It's a dynamic that's made it really hard for people to actually solutions-based approaches to headaches and migraines. And that brings us to today, where I've had Novera Headache Center. This is all that we do here for about 8 years now, and we've helped over 1,500 people from 37 states. And so we enjoy the work that we do, and that's kind of the story.
That's so wonderful that you had that experience with your patients and you were like, huh, maybe there is something to it if a lot of people are presenting with the same symptoms and then they're not really getting any relief, it sounds like. So I want to explore that a little bit more with you, because what you just mentioned was like, people are coming to you with migraines, but they're frequently being mistaken for different types of headaches, or especially I've heard from so many migraine patients who have migraines or experience migraines that they're mistaken for tension type headaches, or sometimes even sinus issues, or maybe like just a stress related pain, because the symptoms of like having that pressure around your head area right here, or dizziness can like overlap. So why are so many chronic headaches and migraines misdiagnosed or poorly managed?
Yeah, most of the diagnoses, when we look at the migraine category especially, we can get into whether it's cluster headaches, migraine with aura, without aura, what's called vestibular migraine. There's even atypical migraine. So there's all these different categories that are all symptom-based, meaning that your symptoms are provided, you just describe what's happening to you, to your provider, and then the provider basically puts it into a diagnosis and gives it back to you. But the problem there is that the diagnosis is only attached to symptoms. It's not attached to anything objective that's like an actual underlying problem. And so when, for example, like when your friends are saying like, hey, I feel like I have migraines, but they've told me it's tension headaches. The reason that it's important, even though they're all tied, generally they're tied to symptoms. The reason it's important is because when someone hears that they have a migraine diagnosis, or they're communicating to a coworker or their boss or to a family member, the migraine diagnosis tends to hold a little bit more weight when it comes to understanding or communicating the disability involved. So the debilitating nature of the symptoms. And so when I'm looking at those diagnoses, that's part of the validity of it, is like, okay, if you have this debilitating recurring migraine, this head pain, then slapping the migraine diagnosis on it is helpful in that regard. When it comes to like the misdiagnosis portion, that's really just because we're trying to take symptoms and put them into nice packages that then, guide people through our healthcare system. And because it's not tied to anything objective, it gets kind of squishy. And people's diagnoses are sort of like you kind of fall in one category and kind of in another. And so without the objective anchor, it just, people get lost. They feel like they don't really know what they have. And that's very, very common. And so what we need to do is find the objective thing that's wrong. And then there's clarity.
Yes. So, yeah, that's it. I want to underscore what you just mentioned, that, yeah, we need to define what is happening to the patient, what exactly is the cause of their headache. And yeah, if we can be objective about the diagnosis, then we can proceed from there. So a big part of diagnosis is testing, right? And I believe, and I could be completely wrong, because that's why this topic is something that I want to learn about too more. So I was like very excited to have you on the podcast. I believe there is a lack of testing as far as like headaches are concerned. There's no blood test, right? You can't go and get your blood drawn and the labs come back and you're like, oh, well, okay, we can define this as migraine headache, or we can just define it as a stress-induced headache. So are there any scans to diagnose primary headache disorders or any other subjective maybe history questions that you're looking at? How do you test for migraines?
Yeah, I'm gonna use something you just said, which is the term primary headaches. So there are two classifications of headaches when we're looking at the diagnosis. There's primary and secondary. Primary by nature is saying that the headache itself is the problem. And so because migraine is classified as a primary headache in that world, so I'm describing how our healthcare system operates, but then I'm going to show you the problem. But in that world, they would just stop at like, the headache is the problem. Let's treat the headache as the headache itself, right? That's what a primary headache means. The secondary headache means that the headache is secondary to some underlying thing. Okay. So we want headaches to be secondary because when we understand that there's something wrong that's causing your head to hurt, then we can fix that thing. When it's a primary headache in our current model, it basically just means you take medication. So when you're receiving the diagnosis of a migraine, there are tests that are typically done, but they're not done in order to provide the diagnosis. There's nothing attached to the diagnosis, but the common tests that are done are like an X-ray or a CT scan or a brain scan, maybe an MRI, maybe blood work, but they're basically just kind of looking at your head, at your neck from a they're looking at the bone structure, if there's any occupying lesions like tumors, if the blood vessels are good, if there's any sign of stroke, that sort of stuff. And those things are like, our healthcare system is very good at catching the things that will kill you, essentially. And so you walk in and you say, my head really hurts and it's debilitating. And they say, okay, like, let's make sure you're not dying. They do those images. And it's like, okay, well, since you don't have the things that are killing you, then let's go back to the symptoms, and they kind of match this diagnosis, and then you take this medication. So that's like an oversimplification, but that's essentially what's happening. And so there are tests, but they don't really guide your diagnosis or what your treatment looks like. Now, what we do is we look at movement. And so the reason that X-ray, MRI, CT scan, the reason these things don't catch it is not because they're like looking in the wrong spot necessarily. Like, MRI, CTs of the neck are very common, but it's a still image. And our bodies were designed to move. Like, our heads can turn, look up and down, side to side. And our heads are heavy and our neck is very mobile. And especially the upper part of the neck it has a lot of dynamic movements to it. And so what happens is stress builds up over time, or maybe you had some sort of trauma, whiplash injury, something like that. And the neck is stressed out, it's irritated, but it's more so a movement problem. So it's compensating in how it moves. And so what happens is the upper part of the neck basically sends a signal to your brain. The brain perceives it as coming from the head or the face because it meets up in the brainstem. So think of it as like a processing area in the brainstem with information from both the face and the neck. So face, neck, meets in the brainstem. The brain then realizes what's happening and it says, is this a neck thing? Is this a head thing? And since the pain signal is so bad, it's just like everything hurts. And the presentation of pain can be squishy, meaning it can look different from person to person. But when we find an underlying thing that can send pain to the head or the face, that's the objective part of this. And so it's usually a movement problem. And so what we do is we evaluate movement, we put pressure through the neck, we try to reproduce or see if there's sensitivity through these areas. We see how the specific joints in the neck are moving. And if there's compensation patterns, we look at the jaw, the shoulders, anything that can kind of contribute to the neck sending a pain signal. So that's what we would look at.
I want to underscore what you just said, that our bodies are built to move. We are built to move, right? I mean, yeah, we do sit long hours in front of our computers and at our desks, but we're still moving in some way or form. And especially if you take just the head and neck section of our body, like our head can rotate 360 degrees. And then imagine the range of motion that cervical spine has, right? So I really love that you are actually taking a look at all these structures, not only in their static posture, but how does that static posture maybe postulate to when you're moving? What does it look like? And is there any dysfunction there? And is that maybe what is causing your headaches? So let's go over a few top root causes for headaches that you have found in your practice.
I think what I'll do here is talk about our framework that we use. It's relatively simple, easy to understand, and there's three things. So when I'm talking about the neck, that's really the spoke in our framework. So it's kind of like a three-legged stool. Okay. Now, the first thing that we look at, the first leg in the stool, is that the pain needs to come from somewhere. We at Novera, we don't assume that the pain is manifesting out of nowhere, that the brain's just making stuff up. That's what our healthcare system will tell you. We don't believe that just because we've seen it over 1,500 cases in 8 years of doing this. And so what we look for is a neck problem primarily, but usually the jaw and the shoulders are involved as well. So that's the first thing, is understand why you would have pain in the first place. Okay? So neck, jaw, shoulders, dysfunction, tension, all of that builds up. The second thing we want to look at is what we call developmental barriers. So think of someone with hypermobility. There's a diagnosis known as EDS or Ehlers-Danlos. It's just someone who's like kind of Gumby, or they're really flexible. They usually lack some stability, and that can mean they are compensating kind of throughout their body. So that can be something that sort of predisposes someone to develop a neck problem. The other big one is airway. So if someone's airway doesn't develop like it should, and they breathe out of their mouth, or they have a hard time breathing through their nose, or they have sleep apnea, oftentimes they're cocking their head back when they're trying to sleep, and they're trying to force air, through their mouth, and their tongue gets stuck, and then they're thrusting their jaw forward all night. And that just causes a lot of tension, which leads to headaches. So that would be an example of a developmental barrier. So that's the second stool in our three-legged stool. The third is what we call your general health, or the systemic side, meaning your whole body. And we look for things that would impact your body's threshold for pain. This is going to be things like food triggers. So if you've ever changed your diet, or heard someone talk about how diet or changes in diet or cleaning up your diet can help with migraines, what that's doing is increasing your body's threshold for tolerating pain, reducing inflammation. Hormones being balanced is another big one in this category. If you have extreme shifts in your hormones, for our female patients and hormonal migraines, like the hormones aren't causing the pain itself. It's just making it so it's really hard to tolerate the neck issue at certain times of the month, or when you have those dramatic shifts. Stress. For your listeners, when they're at work and they're stressed, stress is something that makes it harder for you to tolerate something like a neck issue. So people will say oh, I'm having headaches, but they're just stress related. Well, everyone has stress in their life to some extent, but not everyone has headaches. So we need to evaluate all three of these things, right? We need to understand your overall health. We need to understand what's actually driving the pain itself, and then look for the barriers or the reasons that it might be there in the first place. And then when we have that comprehensive approach, we start to understand like, okay, here's what's actually happening in your situation.
Yeah, no, I like it how you just categorized all the different ways or the root causes of migraines and or headaches. Okay, so I want to dive into all of them right away, but let's go one by one. The first thing you mentioned was structural, and I think that is where your posture comes into. And a lot of my own patients and people who listen to this podcast, they are here, hunched over, rounded shoulders, neck forward, 8 to 10 hours at least. And if they have a longer commute where they're driving, again, doing this the whole time, maybe add another 2. So we are talking about like half of the day. If we have 24 hours in the day, so 12 hours they're spending like this. So I want your opinion on that. Like, how does that impact, or does that impact headaches, or can be a root cause? The second thing you just mentioned structurally was people who are hypermobile. And I've seen a few patients who are hypermobile. They found out way later in their life because they always knew something was off. They would go to their pediatrician and something was off, but were never diagnosed as being hypermobile. And it's kind of like a two-way thing where they can't lift heavy weights, like they can't build a lot of strength too, because it's so easy for their joints to just give in, and they don't even their brain doesn't register that kind of pain because they're just so flexible. So how does the cervical spine structure and then how are headaches related to those patients? So let's explore that first.
Yeah. So the first category, when you talk about prolonged sitting and the office desk work, it's important to understand the physics involved and the dynamics at play. One of the assumptions that we run into is they overlook the sort of dangers. I don't think that word's too dramatic, but the dangers of prolonged sitting or sedentary lifestyle. And so if I'm going to describe or give a word picture of what's happening, your head weighs about 10 to 12 pounds. And so think of it like a bowling ball, one of the lighter bowling balls, but one that weighs 10 to 12 pounds. And if I were to hand that to you and say, hold this, you would likely shift the weight of the bowling ball to one side or the other. And so you wouldn't necessarily hold it in one spot, and you definitely wouldn't hold it way out in front of you because that would increase the perceived weight of the ball. And what you intuitively are doing are distributing the weight and moving it, right? So the weight isn't just in one position throughout the day, because if it was, the stresses placed through your body, through your arms, would be significantly greater than if you were distributing the weight around and moving. And so the same is true for our head. Our head actually weighs 10 to 12 pounds, and it's on a very mobile neck. And so when it comes to prolonged sitting, not only is it like holding a bowling ball in one position and not moving it, but you're actually holding the bowling ball out in front of you. Not as far as you can, but to a certain degree, you're holding it out in front of you, and you're just sitting there like that. And so if you were to try that with a bowling ball, you would fatigue relatively quickly. Now, our neck is able to tolerate quite a bit of load, but what happens is that amount of stress, I would put it in the bad stress category, not like good stress, like you're going to work out and you have muscle breakdown and then you build it back up. This is bad stress. Like it's the amount of stress that your neck over time is having to figure out how to tolerate the load, and that stress is then translated into the joints themselves. The muscles, they fatigue, they wear out. And so you've got like this tension and compensation that builds up because you've basically trained your body to do this one thing, but what it wants to do is move. And so when it comes to prolonged sitting, like standing desks, walking frequently, just giving your body little movements throughout the day is hugely helpful. There's something called the NEAT principle, non-exercise activity thermogenesis. And basically it's just like moving throughout the day. So your body wants to move. When you're not moving, it's not like, oh, I'm going to go relax on the couch and give my body what it needs. Your body doesn't need that. Like if you worked all day, go work out, like go sweat, go do something hard. If you have, migraines, the audience I usually talk to, they're like, well, I get 2 to 3 migraines a week and exercise is making it worse. And so there's different dynamics there. But if you can, go exercise because it's really good for your body. And the second thing, so the hypermobility, essentially what's happening there are that presentation is going to lend or cater to them sort of shifting like constantly. So these people can't get comfortable. It's the type of person that they're constantly like doing this sort of stuff and they don't really know how to like not move. And so these people intuitively like just move. Like they know they have to keep walking. They have to move because their body doesn't like it when they're still because they don't know how to, they don't have like the ligament structure or integrity kind of to maintain a static position. So they oftentimes don't have the luxury of just like sitting still. And oftentimes these people are like gymnasts or acrobats or like they have careers in other things because they just dancers. Yeah, 100%. And so, that's usually the dynamic, like the shifter is usually how that presents. But they need stability. So they still need exercise. They still need to strengthen and improve their conditioning. Oftentimes these people like pride themselves on being really flexible. So usually they're like in yoga and you're like, no, like yoga is not really the best thing for you, even though it's not bad. Like we need to focus our efforts in other types of fitness. So anyways, that's usually the pattern I see.
Absolutely. For people who have hypermobility, stability is the goal. A lot of core stabilizing exercises should be their go-to, but then also strength training within means, because we don't want them to dislocate their joints. They wouldn't even know that they did that. Slowly progressing with the weight is the goal. Okay, the second it is kind of structural. You also said it's like developmental, the airway, and then I think it's very much closely connected to your jaw. Have you read the book Breath by James Nestor?
I haven't, but I need to, and I probably am practicing a way that aligns with it because it's been brought up a few times, but I have yet to read it.
Yeah, but he talks about exactly what you mentioned, how our airways have gotten smaller over time because we don't chew on hard food or maybe even raw meat like our ancestors did. And the jaw has gotten smaller. And then as a result, the whole trachea has gotten very small. So how is that connected to headaches?
Yeah, so that's exactly right. When we're a child and there's, we don't have to go down this whole tangent, but just to piggyback off what you said, we've got the sutures in our cranial bones that are forming and then the bone structures developing. And so our body is learning based off of different stresses we place through it, just like when you start to crawl and walk and then, the feet develop and that sort of thing. Like our body adapts to the different stresses that are placed through it. It's very true that our tongue and how we suck and how we move our tongue around in our mouth is developing our upper palate, which then should be broad and wide and then allow enough space for our teeth. In theory, we shouldn't need orthodontia because we should have these big mouths with teeth that are all spaced out appropriately. And then we're able to have a big open nasal passage that is, if we don't, it's because the upper palate's narrow and high and it makes it hard to breathe. And so the idea there is, so when it comes to breathing through your mouth, like you're not producing the like humidity, the natural like flow of air that our body wants. There's basically all different types of illness, disease that can come about from mouth breathing, and especially when it's impacting sleep. And so when it comes to nasal breathing, it's incredibly important, not just for deep sleep, but for overall health and, all causes morbidity and mortality. So they've linked it to all these different things. But when it comes to headaches, we see that there's a few things. When you breathe through your mouth, you have a hard time getting out of the sympathetic nervous system, so the fight or flight response. And so a lot of these people have a hard time getting into that like rest and digest. So normally your rhythm should be, fight or flight, rest and digest. You should be like going in between these two. And so if you're mouth breathing, your body has a hard time getting into that rest and digest state. The other thing that happens is, of course, your mouth is always open. So there's a mechanical component here. When your mouth is open during the day, not only is it, well, this is a tangential connection, but like it's impacting your dental health and your teeth. So you're at the dentist more, and that's not good for your neck, sitting in a dental chair. But what happens at night is your mouth is open and your tongue will kind of like fall back into your airway. And then you're thrusting your jaw forward and you're having to like cock your head back in order to breathe throughout the night. So this is obstructive sleep apnea. And if you have like worn out teeth, if your teeth are cracked, then, and you have like jaw symptoms, popping, clicking, and your neck is tight and you wake up with headaches, then yeah, you probably have an airway issue. So I'm a big fan of breathe right strips or mouth tape, that sort of thing. Just because we need to breathe out of our nose and as much as possible. Even if you don't think you have an airway issue, I would still wear breathe right strips. Like if you've been through orthodontia, like your mouth is probably smaller than it needed to be, and then your airway is probably impacted. But yeah, that's kind of what we look for, both mechanically and then just like overall health-wise. These people usually have higher levels of inflammation, higher levels of stress. The breathing through your nose actually produces, interesting enough, nitric oxide, which is a vasodilator. So it opens up the blood vessels, allows oxygen to get throughout the body, and then it's one of the things that helps us get into that rest and digest state. So that also impacts sleep and overall health.
Yes, absolutely. Thank you so much for expanding on that. Okay, so the next one is, I think, very, very important to most of my listenership because majority of it is female. And I know that a lot of my female listeners are probably wondering right now, could their headaches be linked to estrogen fluctuations throughout the month? Should they consider testing their hormone panels during specific phases of their cycle? How is it impacting their migraines? And I know that women disproportionately have or experience migraines more than men. So is there a role that hormones are playing? And when you're diagnosing the patients, what are you looking at as far as hormonal panel and hormonal levels are concerned?
Yeah, good question. So women are 3 times more likely to experience migraines. So I think there's 2 primary reasons. One is women tend to be hypermobile or more mobile, and so the stability element mechanically is there. And then also the hormone component. So when it comes to the fluctuation in estrogen, the main thing we're looking at is the dip in estrogen. Estrogen's a protectant for pain. And so when your estrogen levels are stable or high, think like during pregnancy, then you tend to be able to tolerate pain better. That's why a lot of women, when they get pregnant, they're like, hey, I'm great. And then, they have the baby and the migraines come back. And so we look at estrogen and we try to understand, okay, not only is it the dip in it, but it's really like if we're having a dramatic shift in hormones, that's also sort of a formula for you having a really low threshold for tolerating pain. And so when it comes to hormones, like I'm usually sending people off to functional medicine, that sort of thing, to do a deeper dive into that stuff, women's health, women's specialists, that sort of thing. But when it comes to hormones themselves, it's usually, we'll take someone through a process, they'll get 80-90% better. And then it's like, they'll still have a less intense headache around their period. And then, we have to either figure out like, okay, is there more we can do hormonally to help balance the hormones? Because it will help if we go that route. And that's just looking at overall health most of the time, improving sleep, diet, exercise, all that stuff. And so, yeah, even hormonal migraines. that are very attached, like once a month, you have a debilitating migraine. Those we treat those all the time, and our clinic, my clinic, doesn't necessarily do anything specifically with hormones like a functional doctor would. But we are working on the underlying source of pain and then making recommendations or referrals for hormone specific treatments.
Awesome. Very, very nice. So then the last one I wanted to ask you about was food. We have, talked about food here with relation to the jaw and like chewing it, but can food sensitivities also play a role in people experiencing headaches and migraine?
Yeah, absolutely. So food and the gut is going to directly impact inflammation levels running throughout your system. And so think of it like we have local inflammation, meaning the neck is irritated and there's inflammation sending a pain signal. And then you have inflammation throughout your system. And the brain isn't functioning, like your body isn't functioning in isolation. It's not like, okay, your neck thing is in this compartment and then your gut thing is in that compartment and then your stress is over here. Like your body's experiencing all of it in real time. And your brain is trying to play triage and understand what it can pay attention to and what it should ignore. And the reality is, when your body is stressed, your brain's going to have a harder time playing that triage, and it's just going to be sensitive to everything. And so when it comes to gut health, if you know that you have a food trigger, some specific food triggers it, then understand that means that it's inflammatory to your system. It's something your body doesn't necessarily like. And you can just avoid that food. I would say the better or the best approach is to really understand your gut microbiome, all that good bacteria, bad bacteria, the balance of bacteria, and work to restore a proper gut microbiome so that your body can absorb properly the foods that you eat. And then ultimately, we want to have a well-rounded whole foods diet, meaning limiting processed foods to almost nothing. I mean, if it has more than 5 ingredients, you should probably question if you should be eating it. So you want your food to like come from the ground, basically. And if we can move in that direction, your body will be much healthier, better equipped to handle pain. And then you'll have more energy, you'll sleep better, that sort of stuff. But when it comes to food itself, we haven't really run into the scenario where it's like, oh, your neck is fine. And like, it's literally just like this specific food that's driving your headaches. And it's the only thing. We got to go back to the 3-legged stool, right? Like the food is in the component or in the category of things that impact your overall health. So maybe increasing inflammation, your body has some sort of allergic response to certain foods. And then that stress makes it harder to tolerate what would be like a neck issue. And then you have a headache. So that's how I would look at those situations. And that's played out with what we see here at Novera. And so, yeah, I'm fully on board with looking at, different diets for migraines or that sort of thing. I would just say, like, not in isolation. Like, it's not the only thing to consider when we're trying to tackle these complex problems.
Absolutely, I agree. And thanks for actually suggesting that it can't be the only thing when it comes to food and its connection to headaches and neck pain. It could be definitely something that is there, also presenting because of food. And whole food, just eating whole foods is beneficial on so many different levels. But the prime benefit, of course, as you just mentioned, is it reduces the inflammation in your body and you feel better all around. So let's talk about the options for patients. Maybe there are things that we missed out on. What can people who are experiencing headache and neck pain do in addition to daily pharmaceuticals and or replacement of those? What are the viable options? What's your approach?
Yeah, I put medication into a category of purely symptom management. So we always want to be looking to treat the underlying cause. And so hopefully medications are just a short-term thing for people, and then we're, getting off of them. The problem is that, if you're listening to this and you've had migraines, you've probably had them for 10 plus years and have been walking around with the triptans in your purse or your pocket. But what we want to understand is that the most likely scenario is that your neck, your jaw, your shoulders, most of the time it's the neck is the primary thing, that there's problems there. And so we control what you can, control what you can control, essentially. Think of it like we live in a world where everyone has tooth pain, no one brushes or flosses. And I kind of feel like a dentist that is saying, you should brush and floss. And people are like, well, my mouth really hurts and I didn't get punched in the mouth, so why would it hurt? And it's like, well, it's just a bunch of little things that have led to what feels like a big problem. But we need to go back to kind of the basics. And so in that dental analogy, yeah, like a lot of people are going to need more than what I'm just going to suggest here, which is, why we exist. But if I'm going to be helpful to the listeners, it's things like, walking and exercise and little movements throughout the day, finding stretches for your neck and shoulders, so that when you are, sitting at your desk, you're aware of the tension that you're carrying, and then you can give your body the movement that it needs. Get a standing desk, make sure your screen height is where it should be. Yeah, going on frequent walks, and then just being aware of things like sleep position and avoiding stomach sleeping. If you sleep on your side, have a good supportive pillow, hug a pillow, put one in between the knees so that you're not rolling onto your stomach. If you sleep on your back, that's great. There's usually not too many issues there unless you're rolling over or breathing through your mouth. Wear a breathe right strip, mouth tape. That way you're breathing through your nose, you're getting good quality sleep. And then, just improve your diet, like eat whole foods, get your energy back, see if you can actually get home in the evening and want to exercise. So really a lot of my recommendations for someone that is just looking for something practical, I sort of lead with movement. Like, think of this as a neck problem. Start considering your neck. Take notes on oh, you had a headache or migraine this day. Like, well, why would my neck have hurt? Think positions, think sitting as a bad thing. Think I watched a movie on the couch or I slept on the couch, but then incorporate low levels of movement throughout the day, stand more, exercise more, and then sleep better, eat better, that sort of stuff. And most people, I think, should see some improvement with that. But like I said, the reason that Novera Headache Center exists is because these can be pretty complicated things to work through.
I agree. The more you move, especially if you're taking stretching breaks, I call them like posture breaks, while you're working at your desk, that's going to be super beneficial. And then walking at lunch hour after your lunch, go for a walk, go for a 10-minute walk. It doesn't take long. It's actually going to make you feel so much better too. Go for a walk at the end of the day. Yeah, again, it doesn't have to be an hour. You could just do 10 minutes and make sure you're doing strength training 3 days a week. Great. These are all great. This is great information for my listeners, and thanks for actually highlighting movement. That's what I preach. So where can our listeners and viewers find you and learn more about your work?
Yeah, the most direct way, if you're like, hey, I just want to go through a personalized approach for my headaches or migraines, go to NoveraHeadacheCenter.com, NOV as in Victor, ERA, HeadacheCenter.com. So, and then on our socials, you can look at Novera Headache Center on Instagram, and then The Headache Doctor is my podcast. So the Headache Doctor podcast, and then on TikTok, the Headache Doctor there as well. And so you can kind of find us either way, Novera Headache Center or the Headache Doctor. Those brands are kind of attached to each other. And yeah, reach out, follow us on Instagram. We're also on YouTube under the Headache Doctor. So you can find us just about on any platform that you prefer.
Awesome. And I have to highlight something over here that your Instagram channel is super informative. It has tons of reels with tips and also the science behind your neck structure and your head and why you get headaches. So if you want to take a deeper dive into that content, definitely follow Dr. Taves' Instagram and YouTube as well. So thank you so much for sharing all this information with us and joining us today, Dr. Taves.
Yeah, absolutely. Thanks for having me.
Thanks. And thanks everyone for listening to us. Bye for now.